Thank you so much for inviting me to speak on the breast health disparities in the era of COVID-19 and to talk about fertility preservation. My name is Joel Amui Bellan, and I have nothing to disclose. So the topic they wanted me to talk about was access to fertility and preservation options for patients undergoing gonadotoxic therapies and with cancer patients. And before I talk about the access for these cancer patients, I think it's reasonable to talk about fertility as a whole, because for patients who are trying to have children, who have difficulty having children, it can be an emotionally stressful situation, psychologically stressful, and sometimes financially stressful. For women who need to do IVF in particular, which tends to be what cancer patients need when they are doing ovarian tissue cryopreservation or sperm tissue cryopreservation. For patients who do not have cancer, but they have to do fertility treatments through artificial reproductive techniques, the process is very long and stressful. And the reason being, initially they have a consultation with the physician, and then to ascertain what their diagnoses are, whether there is a male factor issue, a female factor issue, and what their overall medical status is, whether they are healthy individuals otherwise, and so on. And then once the physician has determined their general status, the physician then has to start them on their medications, usually in the early follicular phase of their cycles. So that means when their period comes. And that is when we tend to get the most yield for the eggs. Even though for cancer patients, we can start them at any time. So for the non-cancer patient who desires to do IVF or artificial reproductive techniques, when their period comes, we do blood work and ultrasound on them and then start them on medications. And most of the medications are injectable medications. Sometimes they do one injection, sometimes they do 2 injections a day, sometimes they do 3 or 4 injections a day, depending on their baseline ovarian reserve and their other medical comorbidities. And the process of doing IVF or fertility for these patients can take anywhere as short as 8 days to as long as 2 weeks, or maybe a little longer, maybe 21 days or so. But normally that process is about less than 2 weeks. And we usually would bring the woman in, if it's a woman, for blood and ultrasound severally in order to make sure we have mature follicles. And once the eggs are mature, we harvest them through an in-office procedure called egg retrieval, and then we fertilize the eggs depending on the patient's or the couple's decisions. So the process of taking the eggs out takes about 45 minutes or so. And the process of working up to that stage can be up to 4 weeks or so. Once we have the eggs retrieved, we can decide to freeze the eggs at that point, or we can decide to fertilize the eggs with the patient's partner sperm or donor sperm or an intimate partner sperm, or we can freeze the eggs by themselves. And then we can do a transfer on the couple when they desire to, as a frozen transfer several years out, or we can put the embryos in right away, like within 3 days or 5 days, depending on the situation. So when it comes to a cancer diagnosis, most of the patients who have cancers, as you all know, are very traumatized by the cancer diagnosis alone. But I think as soon as they have a cancer diagnosis, even though the oncologists are helping to reverse the diagnosis and treat them, if the patients are less than age 49, they should be referred to a reproductive endocrinologist just to talk about their fertility options, because to the non-cancer patient who's trying to navigate these steps, it can be quite daunting for them. So in order to do this, I searched the literature and I thought the best resource was the American Society for Reproductive Medicine most recent practice committee opinion on fertility preservation in patients who are undergoing gonadotoxic therapy or gonadectomy. And it should be noted that usually cancer patients who get chemotherapy, or radiation therapy to the pelvis tend to have iatrogenic infertility. So this, hopefully, my representation will be able to help all of us to be able to help these women, because we have done such a fantastic job in prolonging lives and adding quality to the lives of these cancer survivors. And cancer survivorship has greatly improved. And once these women and men and in between have done well with their cancers, sometimes they just want to have children on their own. And in 2020, we do have that capability of having them to have their children on their own. So the important thing for these cancer patients is rapid access. And of course, it depends on a good interdisciplinary team and collaboration. And why is that? So the oncologist, his primary role is to make sure this cancer goes away or is treated or is under control and gives the patient a better survivorship and a better quality of life. But again, if the woman is less than age 49, it's important for them to talk to the reproductive endocrinologist. They can still be fast-tracked through seeing the reproductive endocrinologist. And there should be one person who coordinates all these so it makes the process seamless and easy for the patient. Talking to the reproductive endocrinologist goes through the same processes as a patient who is trying to have a baby without having a cancer diagnosis, except that with a cancer diagnosis, we have to act very swiftly. The interdisciplinary team also involves a reproductive surgeon and reproductive specialist, just in case the ovarian tissue has to be harvested, or whether they need tissues for orthoptic transplantation of the ovarian tissue. And then if the patients are prepubertal, meaning that they have not ovulated yet or they've not gone through puberty, then you need to talk to ethicists in addition to the family to make sure that you're making the right decision for the patient. You're also going to need counselors, including legal counsel. Mental health professionals are needed because the actual thought of having a cancer diagnosis is daunting. In addition, fertility itself, just to navigate through the process, is daunting. The medications, the injectables, the hormones even though it's the hormonal levels in these patients are elevated intentionally, the ovarian hormonal statuses are in a controlled hyperstimulation status. So they need to talk to mental health professionals just to navigate through the process of having a child. Sometimes patients would have seen a mental health professional, but they don't want to harvest their eggs, or they don't want to harvest their sperm, or they don't want children in any way. And that is okay, but just having access to that helps them to feel more complete. Because initially with the cancer diagnosis, all their thoughts are focused on cancer. But once they talk to a mental health professional, if time allows, it helps them to make informed decisions for the future. For patients who have certain genetic cancers like BRCA1, or if they're Ashkenazi Jewish type cancers, or certain familial type cancers, they may need to talk to the genetic counselor as well in order to know what the risk to the offspring will be should the patient elect to further that genetic mutation for their offspring. And then financial counselors. So certain states have mandates where IVF is covered. Some do not. Some insurance companies are actually lenient, and if a patient has a cancer diagnosis, they'll work with the patients and provide coverage for the IVF cycle. Some drug makers for the IVF would actually provide medications free of charge to the patients if they have a cancer diagnosis. So there are multiple ways of helping these patients. So with a cancer diagnosis, they don't have time to think about, do I have the money? Don't I have the money? Who's going to help me? How much debt am I going to have? And so on and so forth. So having a rounded interdisciplinary team and collaboration would help. Now, the artificial reproductive technique lab is essential, obviously. So for cancer patients, this artificial reproductive techniques lab has to be open year round. It cannot be just open, and closed in the summer or something of the sort. It has to be open year round, and it has to be able to perform the typical processes that we provide for artificial reproductive techniques. And that includes the egg retrieval, the egg freezing, the embryo transfers, the embryo cryopreservation, the sperm production or cryopreservation, and the embryo cryopreservation as well. Trying to move my slide. Okay. So I'm going to focus in on females who are cancer patients and what the currently available medical strategies are. So for females who are going through the fertility cryopreservation, they can freeze their own eggs. It is true that as the women get older in general, whether they have a cancer diagnosis or not, the women are not able to, when they get older, the quality of the eggs to become children diminishes with age. So that age 35 and below, they tend to do very well with pregnancy rates around 46%, which seems low, but when people have sex, if they're young and healthy and there's nothing wrong with them, the pregnancy rates are about 15% at best, or maybe 20% at best. So doing IVF carries a better pregnancy rate. So when the woman gets older, over 40 or over 42, the pregnancy rates go down, whether they have a cancer diagnosis or not. And there's a school of thought that sometimes the cancer diagnosis itself impairs the ability to create enough eggs or gametes in order to have children in the future. But these women do have the ability to use their own gametes. So for the average woman who has a cancer diagnosis, as soon as she decides that she wants to have children, we see them rapidly. We start them on gonadotropins if they're in the follicular phase of their cycle. They use the medications for about 2 weeks or less. And then we harvest the eggs and we give them medication so they do not get sick, like gonadotropin agonists. Women also do have access to donor gametes where the embryos are already created. It's almost like adoption, except that the woman is getting the embryos and growing those embryos into their own womb. So that's a method that we can use to preserve fertility for these women if they so choose. Say they were 49 or 50 and now they decide that they want to have children. They can use donor gametes as well. And donor gametes includes donor eggs and donor sperm and donor embryos. And then there is the autologous or donor embryos. So autologous, meaning that they generate the eggs themselves, and then they can use other people's embryos. So there are couples out there or single patients who have had all their children that they ever want to have. They may have 6 children or 4 children, and they're truly done having their children, and they don't want to discard those embryos. They want to give them to someone who's trying to have a child or who wants to adopt a child and cannot afford to adopt the child. And so those patients have donor embryos as an option. And obviously, there's always adoption. The process of embryo preservation goes through the same process as doing IVF, with collecting the eggs with an egg retrieval cycle, and then fertilizing the eggs, and then allowing the embryos to grow through the cleavage stage or the blastocyst stage, and then cryopreserving them. And in this day and age, we use liquid nitrogen to cryopreserve the embryos as vitrification. and the embryos can be preserved for up to 5 years, sometimes longer, but we usually say to the patients they can be cryopreserved for 5 years, and then they can retrieve the embryos whenever they're ready or when they're free of cancer, and then have the embryos transferred into them. Embryo cryopreservation has been in existence much, much longer than oocyte cryopreservation. And then obviously there's mature oocyte cryopreservation, which is a process where the woman does IVF, again, that 8 to 14-day window of taking the medications and then going through the egg retrieval process. And then the eggs also can be stripped and then cryopreserved. And the eggs can be thawed once the woman is ready, and the women tend to do very well with the oocyte cryopreservation. The issue with embryo cryopreservation versus mature oocyte cryopreservation is if the woman does not have a partner or does not want to use a donor sperm, then she has the option of using the oocyte cryopreservation. Also, if the woman does not want to have to deal with the rest of the embryos, what to do with them once she's done having children. Say she got 20 eggs, and out of the 20 eggs, 16 of them fertilized well and they were frozen at the blastocyst stage, or they were frozen at the cleavage stage, and she's had her children and she's done with the child bearing, then the question is, what is she going to do with the rest of the embryos? Is she going to donate the embryos to somebody else? Is she going to throw them away? Is she going to donate them for research? Or is this going to be a hard decision for her? So for some women, they elect to do the oocyte cryopreservation. Now, there are other medical issues which are non-cancer related, where there is bilateral big ovarian masses within the ovary, where the ovary has to be taken out, or both ovaries have to be taken out for a young woman, say a 21-year-old. In that case, the 21-year-old can have a mature oocyte cryopreservation before we actually proceed with any surgical interventions to remove the masses on her ovaries. Sometimes for some patients, we can use GnRH agonists like Lupron to suppress their ovarian function for a period of time. And then we can, usually these GnRH agonists can last a month or up to 6 months at a time. And then once the suppression is over, they can resume having children with their own gametes, in which case they'll be using fertility preservation using their own gametes. And then there's ovarian transposition. So ovarian transposition is when, an example would be when the woman has, say, cervical cancer, and necessarily the uterus and the cervix has to come out. But the woman is young and she needs to have the full function of her ovaries. So for women of this type, ovarian transposition is necessary. And the way this is done is at the time of removing the uterus with the cervix, the ovaries are transposed up to the abdomen and either clipped with a clip by the surgeon, or it's also suspended underneath the ribs, so that the reproductive endocrinologist, when they're doing a transabdominal retrieval, can access them. Also, for patients who need pelvic radiation, either teletherapy or brachytherapy, will need to have the ovarian transposition done. Now, once the ovaries are transposed, there are times when it's transposed in the arms, and there are times when it's transposed in the abdomen. And the reproductive endocrinologist has to feel very, very comfortable doing transabdominal egg retrievals in order to retrieve the eggs abdominally. And then there's ovarian tissue harvesting. So ovarian tissue harvesting is a process where the women are young, and you can harvest the ovarian tissue either by laparoscopy or laparotomy and take the cortical tissue within the ovaries and freeze them. And then you can use them when they're ready. And you can freeze them for several years before you use them. Usually when you're ready to use the ovarian tissue that has been harvested, it can be transplanted back into the woman, and the tissues can usually resume ovarian function within 2 months to 20 months or so, and they can last in the woman for up to 7 years. There's also in vitro maturation, where these cancer patients have a lot of eggs, or their anti-Müllerian hormone levels are very elevated. And so instead of getting, say, 20 eggs out of this woman, you may get 60 eggs out of this woman, or 100 eggs. The goal is not to get too many eggs, it's just to get enough to get her to have a family. But sometimes the medications that we use can be very potent for these women, putting them at risk for ovarian hyperstimulation syndrome and pulmonary embolism and other embolic events. So for these women, we can do in vitro maturations where the eggs are recruited, and before they get to maturity, we harvest them and then allow them to grow in the lab. And then we can cryopreserve them and use them later on. Now, certain cancers cannot wait. Once we have that diagnosis, we have to act immediately. So ideally, when we wait for the woman to have her period before we start her medications, which are all injectable medications, we do that on the second or the third day of their menstrual cycle. We call that the early follicular phase. But sometimes we have to start right away, because the goal is to freeze the eggs, not necessarily to get them pregnant right away. So we can start the medications right away. And we do use different medications, gonadotropins, to help them to recruit as many eggs as they safely can. Sometimes for these random start stimulation cycles, we need to get the eggs as soon as possible within a 2-week window before they start their chemotherapy regimens. And then I put the use of a gestational carrier here because there are some women who will need to have their uterus out so that they cannot carry the pregnancies, but they have the genetics of that embryo waiting for them until they're ready. So there are several agencies out there, and sometimes family members do elect to help their family member to carry the pregnancy to term. Now, in the US and several other developed countries, to use a gestational carrier, there are protocols that go in place. So before we harvest any of the eggs or any of the sperm or any of the gametes that we need to go through strict additional FDA testing on the egg donors, or in this case, the cancer patients, to make sure they don't have any diseases to give to the person who's going to carry the pregnancy for them. And for cancer patients, it becomes difficult to make decisions about the disposition of the embryos. So they may have an embryo, they may have completed their childbearing, they survived the cancer, they got pregnant without using a gestational carrier, or they ended up using a gestational carrier, but they have several embryos left or several gametes left behind. What are they going to do with it? They can opt to donate the embryos, or they can have the embryos assigned to someone they know to make decisions on those embryos. But before the embryos are harvested, it's important to have a disposition, the thought of the disposition for the gametes or the embryos in case they should prematurely die. So I cannot talk about having children or doing fertility without talking about our male counterparts. So for the males, they could have, if they are post-pubertal, they could have an ejaculated sperm for cryopreservation. And the average male makes about 20 million in the ejaculate, or 100 million or so in the ejaculate. Usually we have them make at least 2 or 3 donations so that we have ample sperm to fertilize the eggs. Now, even though they make several million sperm, only one gets to fertilize 1 egg, typically. But sometimes we need to get more of the sperm if we need to do ICSI, or if we need to wash out the sperm, or if the sperm has several morphology issues or motility issues and so on. So the more sperm that they can cryopreserve, the better. Some males with the cancer diagnosis are not able to actually even produce because they're so overwhelmed, stressed out. And so for these males, you can use phosphodiesterase type 5 inhibitors to help them to have an ejaculate. There's also vibratory stimulation, and then that can be used for some of these males. And then there's electroejaculation. Electroejaculation is done in the operating room and is done transrectally using a probe to stimulate the prostate and the seminal vesicles. And it's done with the urologist. And usually these patients will be able to have sperm ample enough to have children with. Now, for all sperm, whether they have adequate semen parameters from just a normal ejaculation or whether they have little sperm, meaning that they were making 10 million in the ejaculate rather than 20 million or rather than 100 million. Sometimes they may only be making 10 sperm or 5 sperm or 20 sperm in the ejaculate spermatozoa. And you can still get the woman pregnant with that doing the process called ICSI, which is intracytoplasmic sperm insemination. Now, sometimes they have prepubertal children who are not able to have an ejaculated sperm. So together with the cancer diagnosis, together with the stressors, together with the fact that they've never been sexually active, or together with the fact that they have never had an ejaculate, they don't know how to produce, they don't watch videos that help them to produce the sperm, it makes it difficult. So for these people, electroejaculation may be an option for them. There's also some men will have an ejaculate, but then the sperm goes into the bladder, retrograde ejaculation. For these men, they can be given alpha agonists and Sudafed, and that helps to reverse the retrograde ejaculation. And there's times when we have to spin the urine in order to get the sperm after they have ejaculated retrograde in a retrograde fashion. There are some men who they may have an obstructed vas deferens, or their sperm just doesn't come out, just sits in the testicle for some reason or another. The testicular, or they've had a vasectomy for some reason, now they have a cancer diagnosis and they have a new wife and they want to have children, and so on. So with the help of the urologist, the testicular and epididymal sperm extraction can be done in the office as a same-day procedure under MAC or local anesthesia, and then the surgically extracted sperm can be cryopreserved. I did not talk about microdissection of the sperm, which tends to be for much severe oligospermia, or for patients who just are completely azoospermic, where they are not making any sperm at all. Some people have toyed with the thought of giving men gonadotropin releasing analogs to suppress their spermatogenesis, but it has not been proven to be appropriate in males and has not generated future children. So it's not appropriate to use GnRH analogs. And then if the men are young or the boys are young, the testicular tissue itself could be extracted as well, and it's considered investigational. So for cancer patient, I cannot emphasize enough that if there is any way that we can have a prompt counseling and consultation with a reproductive endocrinologist with these cancer patients, once their diagnoses are made, before they start any treatments, that would be the ideal situation so they can make informed decisions. It's important for them to come with a family member or a friend so that they can at least hear what is being said. Some of them, like I mentioned previously, they are so overwhelmed, they're not able to make decisions right away. They think, I'll just adopt, and they think that's what it is. And then once they've survived several years, they wish they had. But even if they wish they had preserved their gametes, we can still get them pregnant. They just need to hear what is available to them. So currently, the main principal established modalities for preserving fertility for these cancer patients are embryo cryopreservation, oocyte cryopreservation, and ejaculated or testicular sperm cryopreservation. However, we can still cryopreserve ovarian tissue. Insurance companies do pay for it now, so it's no longer considered experimental, but it's an invasive process, obviously. You need a laparoscopy, and you also need or a laparotomy to cryopreserve the ovarian tissue. Testicular tissue cryopreservation is still considered experimental somehow, but there are several other things that can be done, like what I had mentioned previously: the sperm cryopreservation, for those with retrograde ejaculation, giving them Sudafed or giving them vibratory stimulation or electroejaculation, and in consultation with the urologist doing testicular epididymal sperm aspirations for these men. And in rare cases, you can do microdissection of the testicular tissue. And again, the goal is to get these tissues before the toxic radiation or the toxic chemotherapy is administered to these people. And then GnRH agonists can be given to women with breast cancer, for instance, just to protect the ovaries temporarily until the treatment is done. And then they should resume their full course of function of the ovaries. However, GnRH agonists are not good for males. And then ovarian transposition certainly is available, but for women undergoing pelvic radiation, but whoever the surgeon is or the reproductive endocrinologist is must be very comfortable doing transabdominal egg retrievals. So again, once these people, these cancer patients who are on their way to recovery, desire to have children before they're treated, they should have the ability to cryopreserve their eggs. They should have the ability to cryopreserve their embryos if they have a partner, if they choose to use donor sperm, and they should be able to cryopreserve their sperm. These are some of the medications that are available as injectables. You can see the needles here that they have to use as daily injections as needed, and sometimes they hyperstimulate, and sometimes they get very hormonal, and sometimes they feel very bloated, and sometimes they get ovarian hyperstimulation syndrome where they are placed in the ICU until the ovarian hyperstimulation process is gone. So for these types of patients, especially these cancer patients, we don't want them to be sick, and let alone for any other patient. So we use gonadotropin agonists, dilute gonadotropin agonists as a trigger shot to help with the final maturation of the oocyte before we harvest the eggs. And usually they tend to do well, and they return to their spontaneous menses in about 7 days, and then they go ahead with their chemotherapy regimens. Thank you.